Hi, welcome back to Arthritis Now, and to part 2 of our interview with Dr. Scott Canna, who's studying juvenile arthritis. If you missed part 1, you can check it out right here. Remember, July is Juvenile Arthritis Awareness Month, so be sure to check out curearthritis.org for all the latest research updates. Now sit back and relax as Dr. Canna answers one of your questions. And what do you think needs to be done to kind of raise that awareness of juvenile arthritis? Because, you know, the connotation of arthritis is usually older individuals that get it.
The field of pediatric rheumatology is continuing to blossom. If you look at just the numbers of pediatric rheumatologists that are out there, there's more and more and more each year. There's still a lot of underserved areas, especially rural areas. Mm-hmm. But increasingly, there are more people who are specifically trained to treat children with autoimmune diseases. And you know, we're obviously quite attuned to the differences between childhood and adult arthritis.
And what made you want to pursue this specific kind of juvenile rheumatology? Did you have a personal connection at all, or was it just something that was of interest to you?
As a medical student, I took a year off to do research and came here to the NIH. And was actually guided to work with someone here in NIAMS who really sort of opened my eyes to what an amazing field this is, what an amazing group of kids you get to work with, and what amazing potential there was. You know, this is a really interesting time in the world of immunology where almost every day I can't even keep up with all of the new biologic drugs that are coming out in different fields and which ones are going to be useful in which context. We just don't know, but it's exploding, and it's really exciting to be a part of that.
Okay, so we have a question from Britt Johnson, also known as the Hurt Blogger, who is a rheumatoid arthritis patient and also a Cure Arthritis ambassador to our foundation. And let me read you her question. She says that what criteria is available for seronegative juvenile arthritis patients seeking diagnosis? How can patients with clean x-rays and labs get better treatments when it's written off as either growing pains or psychosomatic symptoms?
Not all of your viewers may know what seronegative means.
So you could explain that.
So when you are trying to make a diagnosis, especially of rheumatoid arthritis, you'll look in the blood for a couple tests, particularly something called rheumatoid factor. There are a few other antibodies that people look for. And when people are looking in the blood for antibodies, particularly, they're called serologies. And so if your antibodies are negative, it makes it less likely that you have rheumatoid arthritis. And so they call that seronegative.
Okay.
But as I kind of said before, most kids with arthritis will be seronegative. Those tests will be negative. And so the absence of a positive rheumatoid factor really doesn't tell me much, except that the rheumatoid factor is negative.
Right.
So, you know, the best way to know if someone has arthritis is to go to someone who is skilled in diagnosing arthritis by physical exam. Sometimes radiology tests are helpful. X-rays are really good for looking at bones, not as good for looking at other things. So sometimes they'll order other tests like an MRI. But finding someone who's skilled in making that diagnosis, particularly in a child, is helpful. And as I kind of mentioned before, I think, you know, if you have a child who is having a lot of joint complaints, I would certainly seek out a pediatric rheumatologist. And you know, I have to say that, you know, of the new patients we see, certainly not all of them have arthritis, and that doesn't mean that we can't be helpful in some way or another, because that's, you know, not all that we do. We're sort of skilled in evaluating people with musculoskeletal complaints.
Is there anything that you would like to add, or maybe what you're working on next, or what you might have coming up?
One of the things that we do a lot of, and people outside the NIH do quite a lot as well, is to look in your DNA. Not necessarily you specifically, Kyle. I don't know how you're feeling today, but
my DNA.
Look in a person's DNA to see if there are some hints as to what exactly made them sick. And so we, along with another group that's up in Yale, and it's always good to have sort of independent confirmation of the things you're seeing,
Yeah.
think we have discovered a new genetic cause for a disease that looks an awful lot like macrophage activation syndrome. And this came about because there was a patient who, kept having recurrent episodes of macrophage activation syndrome, and her parents were healthy, and she had this starting when she was very young, and we said, well, maybe this is something in your DNA, and we now have the technology to be able to look in her DNA and compare it to her parents' DNA,
Wow.
and we found this change, and then we, did some science, which is what we do, and we're now, pretty confident that this change that this young lady had in her DNA is what's causing her to get recurrent macrophage activation syndrome. And so that's good for her. It's not going to be a super common thing. Not everybody who has macrophage activation syndrome is going to have this change in their DNA. But what it does as a physician scientist is says, well, this is a good starting point, because I know that in at least a few people that have these problems in this particular gene in their DNA, that results in this horrible disease called macrophage activation syndrome. And so if I can sort of put together the steps between that gene and the disease, and then if I also have a drug that seems to work, there's a lot of dots that I can connect there if I know how that drug works.
Right.
And that is going to be helpful to everyone that has macrophage activation syndrome, either because they're just like the person that has this genetic mutation, or because they're very different, and those differences are important. So it's an exciting time for us.
It sounds like you're definitely on the right path, and that could definitely change.
And I have to say, this. This is not a plug. Kyle did not make me say this. Our ability to sort of really track down this mutation very quickly, my ability has been in a large part dependent on the fact that the support that the ANRF gave to me has enabled me to hire someone who's just out of college, but basically a smart person with another set of hands, and has made it able for us to work almost twice as fast and get a lot of important work done. And I'm unbelievably grateful for that.
Well, we're happy that we could have helped, definitely. And it sounds like you're onto something great. So thank you for sitting down to speak with us. We really appreciate your time, and yeah, we look forward to seeing what you come up with.
Yeah, we'll keep you posted.
Okay, great. Thank you. Thanks for watching. Make sure to subscribe to our YouTube channel, and don't forget to share this video to help spread awareness of juvenile arthritis for the nearly 300,000 children in America affected. Together, we can cure arthritis.